It's not uncommon for patients after cataract surgery, whether that be a month or 6 months or a year or two afterwards, where the patient develops a secondary cataract, or otherwise known as posterior capsular opacification, PCO.
And it's kind that you say it uncommon. I'd say it's very common, and it can be what I usually tell patients: weeks, months, years, decades later. Doesn't matter. We treat it with a YAG. YAG is yttrium aluminum garnet, I believe, a laser that provides little explosions. There's two little red dots that are harder to see here, but they serve as focusing power. You saw me focus right there. Focus on the posterior capsule. This provides those little bursts that blow up, for lack of better terms, the posterior capsule. Different ways of doing this. One way would be to create a large ring, almost like a posterior rhexis. The challenge that I have found with this is sometimes that ring doesn't fall back, and then you still have occlusion, obstruction of the central visual axis, or sometimes it falls back completely, and now you have a large floater.
Would there be any advantage? Here's the second YAG that we're going to start looking at as well, but any advantage to just doing the cross pattern then?
That's usually what I do, the cross pattern, because I know it's open. Why people don't like it is because we don't like to go straight to the visual axis if there's potential for pitting, which there always is. Pitting would mean that the laser doesn't only treat the capsule, but also treats the lens. So there's always an offset, meaning wherever I focus, the laser actually fires behind, which also means that you basically, most of the time, will injure or treat or the anterior hyaloid.
When I see pitting in a patient, I have not encountered a patient who has symptoms from that. They don't seem to be bothered by the pitting in the lens. It's just something I observe on the lens. Is there a concern that you have about pitting of the lens?
There's always a limit. I think most patients are fine with some pitting, but at some point it will be too much. As you can also see, I try to create a large opening. After I've made the initial cross, I go in the quadrants and create another 4 incisions there to let that flap fall back, as you can see here. And then the center part will be nice and clear, and there will just be these little wrinkles, because if the opening is too small, and that means smaller than the scotopic pupil or the pupil in dim light, they might have glare from the edges.
Third example of a YAG out of, we're going to show 4 videos here. Another routine YAG, just coming down the vertical midline first, and that's going to be followed by the horizontal midline, and then each of those quadrants as well that we just learned about. Now, I would assume you want to be very careful not to completely bisect out the posterior capsule and have it free-floating, or is that something that you would intentionally do sometimes?
I would not like to have a free-floating flap, but again, the concern that the lens would dislocate is only a concern with plate haptic silicone. So all these lenses are made out of plastic, different materials. The materials are either PMMA, acrylic, either hydrophobic or hydrophilic, or silicone. There's also a 1-piece versus 3-piece lens design. 3-piece means that the haptics and the optics are made out of different material. And I think previously the first video, if you want to scroll back, was one that had blue haptics. All of these are more a single piece, meaning the haptics and the optics are made out of the same material. And there you saw a brief little example of a pit. Pitting lens materials have different sensitivities to pitting. The acrylics are very resilient, meaning they're also easy to treat. So up here you saw one little pit. Silicone, much easier to pit and also more symptomatic. And then the hydrophilic acrylics are somewhere in between.
Any major complications that you should be aware of after a YAG, other than lens dislocation that we talked about, and pitting? Any other concerns with this?
So if you liberate more lens material, sometimes there's some cortex cap, like inside the bag, that can lead to inflammation, which can cause CME. With any energy inside the eye, there's always the concern about a retinal attachment, although the risk is low. And you want to follow the patient afterwards to make sure to resolve their problems, but you don't need to dilate. Here's a little example of that haptic again that looked like a 3-piece to make sure it resolved things and there's no complications. I like to keep the energy as low as I possibly can. There's different approaches to doing this. I try to do a lot of small little treatments as opposed to a few large ones. Again, up here I think was the other haptic, but there again, surgeons' preferences can vary.
Just taking a step back also to a patient when they first arrive and the symptoms they have, it sounds very similar to what they experienced with the cataract, where they say it's glare at nighttime, difficulty driving at night, they have halos around lights, and it's not an actual cataract, and that's important to remind a patient. This is not a new cataract, it's just the film on the back of the lens that's starting to obscure the vision a little bit.
And the best example of where YAG might be necessary is the patient says, after cataract surgery it was great, and then it slowly got worse. YAG can help.
Yes.
If it never was great, I'm not sure if YAG is the best treatment, and that's a cautionary tale in patients who have a multifocal intraocular lens, because oftentimes the first approach is that they get a YAG. which doesn't preclude an exchange but can make it a little bit more difficult.
Yeah, I like that point. Very important.